thanks very much for coming. Don't worry, not every month will it be me that you have to listen to talk. We're going to get other people involved. This week being March break, it was actually a little tough to get some folks involved. But in the coming months, there'll be a mishmash of people. And I'm still going to plan to attend, though. No, that's okay. So I always want to say thanks to our sponsors. And so far, these are all of the companies that have been approached who have said they're going to support. And I can't 100% recall what the level of sponsorship was for you guys. Pardon? So the bronze level? Is that, or what? Like, because it's sort of done as different dollar values. So anyways, we'll sort that out. We'll sort out where these two companies end up going. But we thank them all because they're all contributing to helping make these happen. So we're going to talk a little bit about acute coronary syndromes. And I just want to remind everyone about all the various risk factors because, of course, that's what contributes to the process of atherosclerosis developing in the first place. And you know most of these classic risk factors over here. But there's a few that maybe aren't quite as, don't get the same sexiness or the same cachet, but just having a certain age contributes to one risk factor. And if you have other things like chronic kidney disease, which sometimes it's considered a marker of atherosclerosis, but actually is truly a risk factor all its own, as are lack of physical activity and obesity, lack of alcohol intake, interestingly, because drinking 1 to 2 drinks per day consistently tends to reduce risk of atherosclerosis, so that's what that means. We still don't recommend starting to drink for those who don't. Someday we may, but some of us I know make up for those who don't. And then, of course, certain healthy diet. So this is the way these atherosclerotic plaques develop, just so you get a feeling for this. And so all the little yellow is the little LDL, just think of it that way. And the little purple cells are monocytes. And so the LDL, once it gets through that endothelium, which truly may just be one cell layer thick, it can start to then attract the monocytes, which become macrophages, and then they gobble these up and form foam cells. And the first steps you'll see is a fatty streak, and then it ultimately develops into a lesion. And here's the thing that's most important for the people out there in the public to appreciate is it's not the high lipids that starts the process going for most patients. How often do we hear people say, well, my lipids were fine? And it's true, they were okay. The thing about it is something damages the endothelium and allows even a normal amount of lipid to get in. And that's often these other risk factors, smoking, diabetes, high blood pressure. Because that little cell layer of endothelium is just one cell layer thick, it doesn't take much to hurt it and allow LDL to get in there and then start this process, which can brew over decades, literally. So we're talking about acute coronary syndromes, and generally they're divided into these three: unstable angina, non-ST segment elevation MI, or NSTEMI, and then a STEMI, the ST segment elevation MI. And truthfully, these two can be extremely difficult to differentiate until enzymes come back. And if the enzymes rise, then it's an NSTEMI, and if the enzymes don't, it can be unstable angina. The issue here is we want to make sure we don't just lob every bit of chest pain ever into unstable angina. And then, of course, the STEMIs tend to be pretty clear. And we'll go through them all so you can appreciate them. The thing it's actually very simple, and these international definitions have been accepted. And for an acute coronary syndrome, you need to have at least 2 of these: ischemic sounding symptoms, diagnostic ECG changes, and enzyme rise. Now, obviously, enzyme rise will define it into STEMI or NSTEMI. But you need to have it, if you'll notice, you need, by definition, to have at least one of these 2 others. So how often do we have someone come in and there's an elevation of the troponin? It's like, oh my gosh, you've had a heart attack. And yet they had nothing to suggest heart attack otherwise, neither of these 2. So I always like to point out, beware of this dreaded troponinitis that's out there, because troponins now are so sensitive that they'll detect any myocardial injury whatsoever. Unlike our old CK-MB fraction we used to use, which really wasn't very sensitive but was very specific because it had such a high threshold before it was considered elevated. Therefore, if it was high, it really meant coronary syndrome. But there's lots of things that can push up a troponin for other reasons, and many of them are cardiac. Congestive heart failure will put enough strain on myocardium that it can start to release enzymes. Tachyarrhythmia, so if somebody comes in with rapid sustained atrial fibrillation for hours, or even SVT, their troponin can rise. And I've had many times where Emerge has tried to admit someone to me where they've had like a rapid AFib, paroxysm lasted 6 hours, it corrected, no chest discomfort, no ECG change to suggest anything, but the troponin went up to like 0.5, and so they felt they had to be admitted for that. And the fast rhythm all by itself can explain it. Acute myocarditis, so there's clearly a different process injuring the myocardium. If you do a cardioversion or defibrillation, you're giving a good shock to the myocardium, and depending on how many times that's done can clearly rise the enzymes. And now we're getting something a little more rare, cardiac infiltrative disorders. So if you had something like amyloid or sarcoid that was infiltrating in there, it could damage it enough to do that. And myocardial contusion. Usually RV is what's injured if somebody's, say, in a car accident with broad chest trauma. But none of these have anything to do with acute coronary syndromes, and therefore none of these should be treated with aspirin, Plavix, low molecular weight heparin, or any of those. And again, I think a way to remember it is if you were asked the question, what could raise an AST, you could start going through all sorts of things, like the liver enzyme. So you could think, well, could be hepatitis, which could be viral, could be a drug-induced hepatitis, could be hepatic ischemia, could be obstruction of the biliary tree, could be portal vein thrombosis. In other words, there's many, many, many things that could contribute to an AST rise. Well, think of troponin the same way. There's many things that can lead to a troponin rise, and they aren't all acute coronary syndromes. There's some non-cardiac as well to think about. Sepsis. Sepsis hurts every organ, so it's not surprising that a troponin can rise there. And COPD issues, because there can be some transient RV strain. If somebody has a pulmonary embolus or wicked pneumonia or COPD exacerbation, they might get a troponin rise from that too. And even strenuous exercise. We see that with CKs all the time. If somebody's in the gym, we can see their CK rise to 800 just from that sort of exertion. Well, again, depending on what they're doing, if they're doing a lot of bench pressing, there can be a lot of afterload. Say blood pressures can be like 300 over 150 every time they're bench pressing a few hundred pounds, so that can lead to a bit of strain as well. So to make the diagnosis of angina, there's this goes decades back, this definition, but the typical angina is defined as having all three of these: a substernal chest discomfort, onsets with exertion or emotional stress, and goes away with rest or nitro. And you can consider it atypical angina if you have only two of them, and you can generally consider it non-cardiac chest pain if you have only one of them. Now, these are guidelines, so there are always going to be little exceptions, but that's a good way to think about it. So when we make the diagnosis of unstable angina, so let's first talk about the group of people who already have known angina. What would make it unstable? It will be an episode of angina if it was increased in either its severity or how long it's lasting, if they had it at rest or a low level of exertion that didn't previously provoke it, and if it's not relieved by the nitro or rest the way it usually is. So that clearly something has changed. Whereas if people are not known to have angina, here's another misnomer. A lot of people will think first episode of angina by definition is unstable, and I would say that's not the case. It is if the first episode is with the usual amount of activity that they do that previously didn't provoke angina. In other words, it's implying a change. It's a little different if somebody says, you know, for years I've never done anything, and now I've gotten into an exercise program, and I'm going to the gym a few times a week, and when I push myself I get discomfort. That doesn't mean it's unstable. That doesn't imply the lesion has become unstable. It just means now they're starting to demand more physically of themselves, and so that's what's bringing it on. But again, also if somebody had an episode of chest pain at rest that sounded like angina. So when they transition to these acute coronary syndromes, so that's really what we're talking about, an unstable lesion that is changing kind of over hours to days to weeks. So I showed you the lesion forming before, and actually this is more accurate on this animation. These lesions tend to expand outwards long before they expand into the lumen. So that's why even angiograms aren't a good way to screen patients, because it's sort of just the tip of the iceberg. But so this will develop over years and years and years. And if somebody says, oh, I'm worried about I might have angina, what you can do is, well, if you did a stress test, they would pass it because there would be enough flow past this blockage. But when it suddenly ruptures because there's a thin wall there, that's when you get your acute coronary syndrome. If it completely occludes the vessel, that tends to be STEMI. If a lot of the crap goes downstream and gets into very small end branches, that's going to be more likely to be end STEMI. And it'll be unstable angina if it very quickly resolves and goes away. And so maybe that might be a situation where it was unstable enough not to completely block off, but some clot formed, but the body quickly dissolved it, so it didn't lead to ischemia lasting long enough to lead to permanent injury. But that's kind of the spectrum of what we're talking about. So with these unstable anginas, you would definitely not occlude completely. With end STEMIs, as I said, it can occlude, but not as dramatically, and that usually means more end branches, which is why we're not trying to get them to the cath lab as quickly. And with STEMIs, we've blocked it off completely. And so, again, ECG changes can follow the spectrum. Certainly we'll get ST elevation or a new left bundle with STEMIs. These, there can be quite a bit of overlap, like non-specific changes, or there can be, most typically, you'd see ST depression or T-wave inversion. And then again, you'll have elevated enzymes for these two, but normal enzymes for unstable angina. So the acute management, so this is kind of ER stuff in the first brief moments trying to get them stabilized. You want to stabilize them and evaluate them all at the same time. You want to make sure you risk stratify them and focus their care. And so this requires a lot of expertise, and this is where this is the phase generally that our ER colleagues are doing. They're getting an efficient and directed history, trying to learn what they can, while at the same time they're doing everything they need to do to stabilize the patient with the plans that they're going to move to more appropriate cardiac care, whether that be sometimes the floor, most times with these ACSs it's going to be the CCU, or getting them down to a place like Newmarket to get them into the cath lab. So the things that they need to consider initially, and this is all happening all simultaneously, 12-lead ECGs, getting blood work including enzymes, getting IV access, getting them on monitor, basic oxygen, aspirin, nitrates. We'll talk about the therapies a little bit later. And then with this directed history and physical, trying to confirm the diagnosis, often by reading that ECG, identifying if there's complications, and assessing are these people who should be reperfused with either thrombolytic or going on to PCI. So in the history, obviously I talked about the three things that chest discomfort that we care about to kind of make typical angina. But you can try and get a little bit more useful information that helps as well. Palliative or provocative features. What makes it better? What makes it worse? If somebody said every time I take a deep breath or every time I change my position it makes it worse and it feels very sharp in quality, that might make you think, well, that sounds more pleuritic. Maybe that's a pulmonary embolus, or maybe that's pleurisy or a pneumonia that's affecting like an empyema or something. But so those kinds of stories can help a lot. If somebody said it felt like something was tearing right down the middle of my insides, I would think about dissection. And I've seen somebody describe it that way too. Where it radiates can help, again, because angina will most typically radiate up either into the neck and jaw or down into the inside of the left arm, rarely past elbow. What symptoms do they get associated with the discomfort? If they felt a lot of nausea and lightheadedness because they were bradycardic, that might make you think it's inferior. If they had shortness of breath or clear overt pulmonary edema, that can be helpful. Diaphoresis would often go with an acute coronary syndrome. Getting to know their cardiac risk factors, more useful when you're sort of almost questioning the diagnosis, because that helps give you the balance of probability. If they have wicked risk factors, 3 of my brothers had heart attacks by 50, and I'm a smoker and diabetic for 10 years versus I'm a completely healthy 28-year-old, then that helps clarify that. And knowing their past medical history, and not like did they have tonsils out at age 8 and did they have their gallbladder out at age 25, but if they had a cardiac history, that's useful to know. Do you know if you have any heart issues? The reperfusion questions, of course, is how long have they had the symptoms? Do we have ECG changes that suggest it's a STEMI? Are there contraindications to fibrinolysis? Because that's going to be useful to help determine their therapy. For the exam, obviously, again, this is all being stuff that's done in that ER setting. You want to know their vitals. You want to focus on cardiovascular and respiratory systems. But having a good, thorough exam is useful, too, because one of the things you want to try to recognize, for example, new murmurs or new heart sounds. Well, if somebody had a new murmur of mitral regurg, that could fit with an acute coronary syndrome because an inferior MI could hurt papillary muscle function, and so their mitral regurg might be functional, and so they'll develop that. But if somebody had a new murmur of aortic insufficiency that wasn't known before, might make you worry, oh, could a dissection have come right down into the aortic valve and led to that? Tough to know, because unless people say, yeah, I just had an exam last week and there was definitely no murmur there. But it's always something to think about. Likewise, diminished peripheral pulses, which if you don't look for pulses in the feet, you're not going to know whether there might be something like a dissection. They've got great bounding pulses in the arms and nothing in the legs. That's important to know. So trying to get all of that stuff done is useful early on. With the ECG, we'll show you all of these. We talked a little bit about some of the differences. So here, if somebody came in with chest pain like this, you know, if they were 75, I might say, well, that ST elevation could maybe reflect pericarditis, because it's sort of diffuse and there's not really any area that has true ST depression. That we don't count AVR when looking for that. If this person was 22, I'd say that's just early repolarization, which is quite common in younger people. But certainly there's nothing diagnostic about that ECG. Whereas here, if you had somebody come in with chest pain and they've got these deep T inversions all throughout, kind of everywhere, that would be a lot more concerning. They also have prominent R waves in the right precordial leads, which could reflect posterior infarct or right ventricular hypertrophy. There's lots of things that could do. But if the story's sounding ischemic, I'd be quite worried about this. And then, of course, ST elevation, where you get your little tombstones, maybe. You could, what I mean by that, if you haven't heard me talk about this before, you could fit a little tombstone in there, which isn't a good sign, because that often says what they're going to have later on in life. These ischemic changes in the inferior leads with ST depression, hard to know, is that reciprocal changes in another territory, or is there actually ischemia there in the inferior wall? And there could be. If somebody had a nasty lesion in the RCA as the dominant vessel, but the LAD was helping supply flow by collaterals, but now they've occluded their LAD, they could be infarcting the whole anterior wall and could be ischemic now in the inferior wall. So again, getting into the cath lab helps answer all of that. And then left bundle branch block, and really new left bundle branch block. That's quite key. If somebody's had an old left bundle branch block, then the ECG here isn't really very helpful. But you'd want to look for that. And just to remind you what those features are, needs to be a QRS greater than 120 milliseconds. Generally, there's a left axis deviation. Prominent R's in the right precordial leads, prominent S's in the lateral leads. And usually the T wave inversion or reciprocal changes will happen where it's more upright, so in those lateral leads. The troponins, very helpful, to the point where, unfortunately, they're so helpful they're used in lots of situations where we don't really want to know what the troponin says, and as a result, when it comes up, then I think it leads to sometimes some unnecessary admissions. But very specific. So specific means it really helps you rule in the diagnosis of myocardial injury, and even more sensitive than CK, because when it's negative, it's really negative, whereas negative CKs can still miss it. It rises pretty quickly, so that's why we do 2 just hours apart. The thing about it is it can stay up for weeks, a lot longer actually than a CK. So sometimes when I'm on call, I'll get a call about, you know, so-and-so's patient, we've done the 3rd and the 4th troponin, it still isn't falling. You know, they've been to the cath lab, they've had their stent, they're pain-free. It's like, I don't care, and stop measuring them because it's not going to change what we do. And certainly it can be up falsely because of renal disease, because it's cleared with renal function. So that's always something to keep in mind. Not that that's a cause of a troponin rise, it's more like a false positive in that regard. But prognosis, the higher the troponin, the greater their risk. So, for example, if a troponin is essentially undetected, less than, and you know, our levels, by the way, are 0.04, right? So we're talking if it's well below 1, then I really don't care much about it as far as, like, I'm not going to let that be the deciding factor for me. Because as you'll see here, even if they have coronary artery disease, their mortality at 42 days is only 1%. It's extremely low. So I wouldn't let the troponin make or break my decision. That just, for example, if I think everything else is good, I'd want to make sure I got a stress test soon or an angiogram soon, but I don't think they necessarily have to come in when their troponin is so tiny. But as you can see, the higher it gets, all the way up to here, a troponin of 9, they got a 7.5% risk of dying in the next 5 weeks. So, and it just climbs quite significantly with the higher it is. So we care about that. So in the STEMI patient, we want to risk stratify. We'll talk about the STEMIs first. We'll talk more about the unstable angina and STEMIs next. So the main thing we want to make sure of is we want to try and reperfuse them, and we have to decide at a hospital like this where we don't yet have cath and PCI on site, we have to ask, are we thrombolysing these people, or are we sending them for primary PCI, and of course direct all their medical therapy. Because the whole goal here, we obviously want to save as much muscle as possible. Time is muscle. And so the longer we go without opening the artery, the worse they'll be. And as a result of losing more muscle, they'll have more LV dysfunction. So that's what we're really trying to do, is keep their hearts healthier. And we also want to try and prevent major adverse cardiac events, all the things that can go along with an infarct. So congestive heart failure, bad rhythms, which is why we put them on monitor. And don't think that the bigger the infarct, the greater the risk of VT and VF. Tiny, tiny infarcts can have enough irritability that they can go into bad rhythms. So that doesn't always mean it's a bad sign when they have it for their long-term outcomes. And then, of course, treat any life-threatening complications that arise, but ideally prevent all of those. So the steps with STEMIs, the first thing we really want to do is sort out how long have you had the symptoms. If you can get them to the lab within 90 minutes of the onset of symptoms, that would be most ideal. If it's less than 3 hours at this hospital, as long as there wasn't a contraindication, we'd say, well, we're going to thrombolyse you, because that's generally the guidelines now. Within 3 hours, go ahead and reperfuse with thrombolysis. Works about 70% of the time, but the clot is fresh enough that it has the best chance of being dissolved by the fibrinolytic therapy. But is it a high-risk STEMI? And you can use the KILLIP classification, and that's the one thing I'm not going to tell you. I'm going to encourage you to look up what KILLIP is. It's a very good way to help sort out how bad an infarct is. But the higher the risk, the more aggressively we need to get these people down to the cath lab instead of fibrinolysing them. Make sure they are candidates for thrombolytic therapy, though. That's key, because if there's a contraindication, that's going to swing them into a different direction. And of course, or are they PCI candidates? How quickly can we get them there? When we pick them up in the field in this region, we ship them right down because we can get them there quickly. When they're in our emerge, we originally tried that years ago, couldn't quite make the window the way we wanted. We're going to try again. We think things have improved, especially with transportation. But we're right at a borderline, and say a place like Aurelia currently couldn't really get them down in time. So keeping in mind about thrombolytic therapy, generally you want to have a good, clear diagnosis. Usually means ST elevation of at least 1 millimeter in the inferior leads and 2 millimeters in the anterior leads, and ideally in 2 leads. You don't want to just rely on one. Or this new left bundle branch block. The idea there being enough injury has happened that it's led to this conduction abnormality that wasn't previously there. Hard sometimes to know. We'll talk about what we would do if the left bundle branch block was old, or if you didn't know a bit later. But if you can clearly tell it's new, that's an issue. They should have symptoms that sound like ischemia at the time that you're starting their therapy. If they say, yeah, I had chest pain that sounded like angina, it stopped half an hour ago and it's all gone, well then you're not really saving as much muscle if they're not currently having the discomfort. And it's got to be less than 3 hours or the clot gets too organized and the success rate is too low. And of course at RVH now we do the transfer AMI protocol. That was a study that came out a few years ago. Warren Cantor at Southlake was the principal author behind it. And it helps shape how we do everything all around the world now, not just in this part of it. What we do now is we sort of drip and ship. We start the thrombolytic and send them down to Newmarket without waiting. The idea there being if things are still brewing by the time they get down there, they'll open the lab and get them into the cath lab. If things seem to have settled where the thrombolytic seems to have done its job, then instead they will say, okay, well, we'll let the dust settle. We'll get you into the lab like tomorrow when it's open normal hours. But here's contraindications to fibrinolytic therapy. Prior intracranial hemorrhage, because you'll worry you'll make it worse. If you had known structural disease in your head, like an AV malformation. If you have a known malignancy in the head, either primary or metastatic, because they're very hemorrhagic when you dissolve their clots. If they've had a prior stroke within the last 3 months, interestingly, of course, not if they've had one in the last 3 hours, because then we would give them thrombolytic therapy anyways. Although we use a different one. We use TNK for coronary and TPA for stroke, but I'd be fine with either. Now, this is an interesting one, and it's usually on the lists of contraindications to thrombolytic therapy. Suspected aortic dissection or suspected pericarditis. In one way, you could kind of be a bit caustic about having that on the list and say, well, in other words, a different diagnosis than an acute coronary syndrome. But the reason these get on the list is because they can certainly mimic it. Aortic dissection can dissect into a coronary artery and cause an acute coronary syndrome, or it's a chest pain picture that can sound like it. Likewise, pericarditis can have ST elevation. Usually it's diffuse, but sometimes it's just in one territory. You might just see it in the inferior leads. Tomorrow you'll see it in the anterior leads. So make sure you're correct on the diagnosis, because if either of these get thrombolytic therapy, it can be a lot worse. You can bleed into the pericardial space and cause tamponade because that pericardium is inflamed and irritable. Or, of course, if they've dissected, especially if they're going to rupture, you're going to make that far worse. If they're actively bleeding, not counting on a period, but if they have an active bleeding issue, that can be a contraindication. or if they've had bad head injuries, facial trauma within 3 months, because again, there could be some contusion that will start to bleed. You can see, though, the list, these are the relative contraindications. I'm not going to go through these in great detail, but you can see there's many reasons to sometimes say I'd rather not give thrombolytic therapy. And it's a balance of probabilities, like pregnancy, for example. Well, the reason in pregnancy, we've never tested if thrombolytics are safe to a pregnant woman, but if she's going to die of her infarct and you can't get her to a cath lab quickly enough, that may be an issue. You don't have a choice. Likewise, an active peptic ulcer. Well, we can always transfuse if they bleed from their ulcer. So these are relative, and the absolute contraindications are getting lower and lower. Here, the ideal person for thrombolytic would be less than 3 hours. You can't get them to the cath lab quickly enough, and they don't have any contraindications. But PCI would be preferred if it's available, if you can ideally get them within 90 minutes from door to balloon, if there are contraindications to thrombolytics. If they present late, we will automatically send them to the cath lab because, again, that clot can just start to get so organized if it's older. If they're high risk, or if the STEMI diagnosis is in doubt. Now, I've kind of told you, well, it shouldn't be in doubt. It should be quite clear. But here's where I would say the left bundle branch block. Somebody has a left bundle branch block and you don't know if it's old, and you don't know if, because either you don't have an old ECG or they don't know or they've never had one before. That's a bit tougher, and I'd feel much better about trying to get this person to the lab because they may not have an acute coronary syndrome at all, or they may, but it may be an NSTEMI, and we don't like to thrombolyse NSTEMIs because their risk outweighs their benefit. So that would be one that I would say is a good reason to consider it. But PCI definitely works better than thrombolytic therapy, and you can see all of the blue bars, which are thrombolytic therapy, are higher event rates than all of the orange bars, which are PCI. So, and the biggies like death, MI, or stroke, the 5% absolute reduction there, 7% absolute reduction in long term. Recurrent ischemia, obviously when you give thrombolysis, all you do is dissolve the clot, but the lesion is still going to be there underneath, and that's why usually they still have to go to the lab and get a stent. But if you can stent them as part of the acute coronary syndrome, they won't have to worry about recurrent ischemia, so that's why there's such a separation of curves. Here in the short term, 20% recurrent ischemia versus only 6%, because you kind of dealt with the lesion, not just the clot, but the lesion itself. The medical therapy, I'm going to go over these relatively quickly because you guys kind of know all of this stuff basically, but MONA and BA just refers to the therapies to think about. So morphine does a lot. It helps treat pain, and when pain goes down, anxiety can go down, and therefore sympathetic tone can go down, myocardial oxygen requirements can go down. So it can actually be quite beneficial there. But of course, there's certain things you want to watch for with narcotics. Oxygen, well, we slap oxygen on everybody in the hospital practically, so don't have to remind you about this one. But the thing to keep in mind is that sometimes these patients may benefit if there's some circulation getting through, but if they're a bit hypoxemic, then obviously that'll make a difference. If somebody has an O2 sat of 98% on room air, I'm not convinced giving them extra oxygen makes a difference, but we would still do it. But certainly it's one thing to think about. The N in MONA, nitrates. Now, I would say nitrates don't tend to save lives unless the acute coronary syndrome is from a coronary spasm, which is pretty uncommon but not impossible. But if we're talking about the process of atherosclerosis and a rupture and an unstable lesion and clot and all of that stuff, there's not a lot nitro is going to do. If it's completely occluded and there's no collateral flow, nitro is not going to help much. It could maybe help if there was a bit of heart failure by leading to a reduction in preload, because sometimes we'll slap nitro on CHF patients. But otherwise, unless there's collateral flow, this dilating a coronary vessel that's completely blocked off isn't going to do much good. It can be really bad if there's RV infarction associated, which is usually in the context of the inferior infarcts, because if you start losing RV function, you're definitely dependent on your preload. So we don't want nitrates. We want lots and lots of fluids and maybe inotropic therapy as well to support them. And of course, if they've been on any meds for erectile dysfunction, then nitrates become a contraindication. You remember that movie As Good as It Gets when Jack Nicholson was so, oh no, I don't use that stuff. Oh good, because this stuff could kill you. And he's pulling it out when he realizes that he couldn't lie about it. Aspirin, very often if they've been brought in by EMS, this is already dealt with because they're very good about giving them aspirin. We want to chew it. The whole point of chewing it is it gets into their system very quickly compared to swallowing it, letting it dissolve and go through hepatic metabolism. But by chewing it, they'll get, and we usually aim for the 160, so 2 baby aspirins, just chew them up good and get them into your system. And it leads to interfering with the platelet component of it. And so platelets are a big part of that clot. They're the bricks, if you will, of the bricks and mortar of a clot. And so interfering with their function has a huge impact, and it will often be one of the things that may have prevented acute coronary syndromes in the past. And that's why once somebody has atherosclerosis, we typically want them on aspirin long term. It can definitely reduce mortality. In fact, in our original thrombolytic trials, looking with like streptokinase back decades ago, aspirin did as well as streptokinase at saving lives, and the two did better than either alone. But again, there's, careful with peptic ulcer disease or bleeding disorders, but I would still give it. Careful means I'd watch maybe more closely for stuff. I'd say the only real contraindication to aspirin is if you know they're truly hypersensitive to it. If they're going to have an anaphylactic reaction, I would stay away from it. And now the BAH beta blockers. Now the beta blocker data is fairly old, actually. We haven't done much beta blocker studies in our more contemporary management where we get a lot of these people to the cath lab, but it still makes such intrinsic sense. We still think about getting them beta blockers very quickly because lowering heart rate, lowering myocardial contraction means lowered oxygen requirements, means maybe you'll save some muscle, and it had a big reduction in mortality back then. With the issues, though, be careful with CHF, be careful with low heart rates or heart block or hypotension. And the A in BAH, ACE inhibitors, ARBs rarely will use. There's one trial that really showed it could be used in place of an ACE inhibitor, but we still tend to think about ACE inhibitors. This isn't so much right in the ER, but kind of within those first 24 hours we'd want to think about it. So that might be something more up in the CCU or on the floor. And then the one ARB that showed it was beneficial in place of an ACE inhibitor was valsartan, but we typically go most commonly with ramipril. We have so much better data with the ACE inhibitors for acute coronary syndromes. And heparins. All the heparins are trying to target the mortar of the bricks and mortars. So if the antiplatelet drugs help the platelets, the heparins are helping the clotting proteins that are the mortar portion of it. So we've got low molecular weight heparin and unfractionated heparin. In years past, unfractionated heparin was preferred for the PCIs because you could stop it and it'd be out of their system more quickly, like 4.5 hours or so. But now that they're almost always exclusively radial, they care a lot less because it's a lot easier to tamponade the bleeding after the sheath is out. So really everybody pretty much gets unfractionated heparin. For us in this hospital, enoxaparin is the one we most commonly would use. But you'll see in other hospitals they might use different ones. Fondaparinux is a common one that had some good data behind it. And we usually use, in fact, I would say 72 hours, but it depends on what the revascularization outcome is. And we would use it in combination of all of these other meds. And then some additional things we will think about: alternate antiplatelet therapy in addition to aspirin, certainly in place of if they're not allowed to have aspirin. But so clopidogrel has been around for well over 10 years. We were using it. The CURE data was the study that showed that aspirin and Plavix was better than aspirin alone. Lately, there's been some new players on the field, and ticagrelor is the one that you'll probably see on our order sets coming up as we're going to make a change, because ticagrelor was found in a study to be better than clopidogrel, and we'd like to offer our patients at RBH the best possible. There's another one out there, prasugrel, but it's dealt with more at the cath lab for initiation, not so much in the ER, so that's why I'm mentioning this one specifically by name. Plavix is like aspirin but better, and ticagrelor is similar, but it's got more reversibility, so it can be out of your system more quickly. If somebody needs to go for bypass and they've been on Plavix, they kind of are waiting 5 days. But if they've been on ticagrelor, they can wait less time. And glycoprotein 2B3A inhibitors, this would definitely be a CCU kind of patient, not a floor patient. These are antiplatelet drugs that are IV, and they're much more potent. So we tend to reserve them for the higher risk patients. It inhibits platelet aggregation right at the final common pathway where the platelets start to bridge and connect to each other. So more bleeding risk as a result. That's why it's not a standard thing. We tend to reserve for certain patients. One other thing to keep in mind, aldosterone blockers, specifically eplerenone. Most people think of spironolactone with this class, but eplerenone was found in one trial to be beneficial when patients either had poor LV function with symptomatic heart failure or diabetes. And so if we learn that, then we should, by all rights, put them on eplerenone. I would say most hospitals are actually rather poor at that, including our own. And that's something that we should consider thinking about in the future. Although we are doing such a better job, generally speaking, it's only going to be STEMIs that are going to have LVs this poor, or people who had prior coronary artery disease, because we tend to preserve enough myocardial function that we're not getting that bad in the end STEMIs. And statins. Now, statins generally I would say is, again, kind of like the ACE inhibitor ARB type, within the first 24 hours. I think the earlier we get them in their system, the better chance we have of stabilizing the lesion. And I think we want to try and consider big doses, not like the way you might start them in a family doctor's office at 10 milligrams of something, but it should be either Atorva 80 or Rosuva 40, kind of go big or go home. Helps to maybe stabilize the lesion a little bit as well. So that's something I'm thinking about once they're admitted on the floor. In the CCU, the main things we're watching for is complications. Complications of the infarct itself, so recurrent ischemia if it settled down but acted up again, cardiogenic shock because you've lost too much muscle, or maybe bad things like ruptures of either septum or of the free wall, and the bad arrhythmias, usually the ventricular ones we care about, but atrial fib and flutter can also occur. And then, of course, if we're giving them aspirin and another antiplatelet drug and heparin, maybe a glycoprotein 2B3 inhibitor, or maybe we gave them fibrinolytic therapy, then we got to watch for things that may make them bleed. When we move on to the unstable angina and STEMI group, you know, evaluating for conservative, which I would say is a small percentage of patients, we still want to consider invasive, but we don't need to get them there to the cath lab necessarily in hours unless they're particularly high risk. And we want to categorize them. Are they low, intermediate, or high risk? The best way to do that is with the TIMI score. If you're not familiar with this, I would suggest you follow up on this and kind of not so much commit it to memory. I used to wear a little pocket card around that had the score system, but we're going to again try and incorporate it so it's on our admission orders so that people can see it right there. But there's these points here, these 7 points. So age above 65, at least 3 known risk factors for coronary artery disease, prior evidence of a stenosis that was at least 50%, ST change on the ECG, at least 2 symptomatic episodes in the last day, aspirin in the last 7 days. Interestingly, you might think, well, shouldn't that protect them? But it turns out it correlates with higher risk because it usually means they're selected out as somebody who's at risk. And if they had a troponin rise. And you can see that depending on how many of these factors, 0 or 1 versus 6 or 7 of them, how much their risk of death, MI, or need for revascularization climbs. So anywhere from down below 5% to almost 50%. So TIMI risk scoring is a very good way to categorize it. And again, here, if you have a score 0 to 2 versus a score 5 to 7, you can see what the difference in risk of death is, or MI, or the combination, or again, also the addition of recurrent ischemia. So low risk acute coronary syndromes in this NSTEMI unstable angina group would be, well, they don't have any high, intermediate or high risk factors, obviously. Their symptoms were brief. They didn't have a diagnostic ECG. They didn't have elevated cardiac markers, and especially if they were younger. And in this kind of a picture, I would think if these people had no problems, they could potentially go home with further workup, because that does put them at a low risk. Intermediate risk, when there's either a moderate or high likelihood of coronary artery disease, symptoms were more than 10 minutes, because that is putting them into a different category. T-wave changes, inversions particularly, or slightly elevated cardiac markers, so if it was like 0.2 or something. High risk, clearly elevated markers, clearly ECG change, recurrent ischemia or symptoms despite the therapy, or with heart failure, if they have high-risk findings on a non-invasive stress test, if they have LV dysfunction, hemodynamic instability, sustained VT, and by definition sustained means lasts 30 seconds or longer. So that's why if you ever call me and I ask how long it was or how many beats it was, and it was 8 beats and everything else is fine, I say, well, that's non-sustained VT and it doesn't put them into a different category. Or if they've had previous revascularization, specifically PCI within the last 6 months, because then that means there's a greater chance that that stent may have thrombosed. Usually once they get past 6 months, the risk is lower. So when they've got really low risk, we can start working them up as an outpatient. When they're high risk, we want to get them to the lab. And most intermediate risks we'd want to get to the lab. I suppose if it was 92-year-old Edna May, we might be a little more conservative with her and say, well, we don't want her necessarily revascularize you unless we have to, so because her vessels will be high risk for complications, vascular complications just from the procedure. But by and large, intermediate and high risk mean we're getting them to the lab, and most of the time, these are people who are going to be admitted and get to the lab before they go home. And ideally, within, well, 12 to 48 hours, I mean, yeah, within 1 to 2 days would be the most ideal. It would be a lot easier for us to have this sort of wait time when we have our own lab. And we definitely, if they're high risk, need to get them to lab, sometimes urgently. Just because it's not a STEMI doesn't mean it can't go to the cath lab urgently. That same kind of therapies I was talking about before, and again with our additional antiplatelet therapy, glycoprotein 2B3A inhibitors, if needed, if they're particularly high risk, we'll think about. Conservative therapy would be, yeah, if PCI isn't planned, we'd still use these same therapies. We generally would add clopidogrel. That's the way we've kind of treated these people when we're sort of not planning to take them to the cath lab right off the bat, because it still would qualify for cure. Again, it'd be rare to say I'm going to treat you conservatively, not sending you to the lab, but I'm going to give you a glycoprotein 2B3 inhibitor. That's kind of much more aggressive. So most times I'd say that's not quite the conservative approach. And we want to follow them along if we're conservative to make sure we don't miss them. And I'd say, again, extreme elderly is about the only reason we normally would think about that. And then once we're getting to the end stages of their admission for the acute coronary syndromes, we want to make sure we're treating these. It's amazing how many patients are diagnosed with diabetes when they present with their acute coronary syndromes, often people who maybe haven't seen docs for a long time, but the stress of the infarct process can be what helps manifest their diabetes. We don't want to ignore these, so we hopefully have them on lipid-lowering therapy. We hopefully have them with their ACE inhibitor and beta blocker, that they've got some treatment for hypertension, but we wouldn't want to ignore that follow-up either. Behavioral, this is where a lot of our education is going to help, and cardiac rehab will help address this too. Smoking, diet, being active, getting their weight down to healthy levels, and making sure they understand the disease process. So making sure they understand why some, if not all of these meds are going to be long-term. It's not like an infection. You get an antibiotic, it goes away. Count on aspirin and lipid-lowering therapy forever. Count on beta blocker, ACE inhibitor forever if there's blood pressure issues or LV dysfunction issues. And rehab helps hopefully to get them into a mindset where they start thinking about risk factors long-term and living healthy. So our goals for blood pressure, ideally at least less than 140/90 in our settings, and less than 130/80 if they're diabetic or have kidney issues. And again, we want to, because these have so much cardioprotective evidence in so many trials, we really like to optimize these. So I wouldn't want to have like a tiny dose of an ACE inhibitor and then it's found they have high blood pressure, and so we then say, well, let's add a thiazide, or let's add a calcium channel blocker. Let's add the ones that have better protective evidence, so bump up that ACE inhibitor, and as long as heart rate will tolerate it and no other contraindications, bump up the beta blocker. Our goal for lipids is to get the LDL down below 2. In some cases, we sometimes even think be more aggressive, down below 1.8, which is what correlates with an American target that's more aggressive. And ideally, triglycerides less than 2, but that's not what makes our decisions for us. So maximizing use of statins. So that's not something we would normally address in hospital. We would take them and put them on the maximum dose of the statin we pick, and in follow-up, that's where we're aiming for our targets. And sometimes we have to think about ezetimibe to get them there as an alternate medication to work with it, but with the statin, or in place of if they don't tolerate it. The other meds that are out there, like fibrates and niacin, we don't typically consider, not in the acute phase. And then diabetes, the goal being get a hemoglobin A1C down below 7%. So sometimes we might need help from diabetes, the diabetes clinic for that. They may end up going home not only on the cardioprotective meds, but maybe they'll be on metformin and gliclazide, or maybe even insulin, and certainly follow up in the clinic for their own education. Smoking cessation is huge. It's amazing how easily people quit smoking in hospital. How often we've heard, oh, that was no trouble. I never craved it, not once when I was in hospital. And I would say the biggest reason for that is because it's a huge change in their routine. Smoking is so often an addiction, but also a habit by association. So it's hard for them not to have a cigarette if they have one every time after they have supper and read the daily paper, or if every day in the morning at their coffee break. So in hospital, none of those things are happening, so they don't have that association, so it's easy for them to give it up. But once they get back to their routines, the cravings start to come back. And definitely when there's a situation of a stressor. That would be the most common reason why somebody was maybe off cigarettes for 3 months or 6 months and then they go back to it. It's because something stressful happened, work or health related or family issues, and the best way they knew how to cope with stress was cigarette smoking, so they go back to it. And we want to emphasize that. And there's meds that can help, and there are certainly lots of counseling that can make a difference too. And physical activity, hopefully cardiac rehab addresses this substantially. We try and reinforce to these people, when you're finished the 12-week program, that doesn't mean you're done. Again, it's not like an antibiotic where once you're finished you go back to being a sloth. We want to make sure you try and maintain these behaviors long term. And it's also a great way to have follow-up for 3 months after their event. And diet, hopefully again with education, they're starting to adopt some healthier lifestyle choices. Physical activity, remember, like there's lots of ways to try and do that. And instead of playing video games where you just sit on the couch, maybe you can try and select some of the video games that are a little more active. And of course getting outside, but having something inside for when weather's bad, like I think a treadmill or stationary bike is nice to have at home. Exercise outside all you want, but if you don't feel like it on one day, you've got no excuse because it's right there for you. It's really tough to maintain long-term behavioral changes, but I think the better we educate these people, the better we'll achieve that. And one of the things we're going to be doing with part of getting our ACS protocols up to date, Amanda's going to be helping a lot with this, we're going to have a better checklist so that patients won't be missed in certain things. We'll make sure that they have all the meds they're supposed to have, all of the outpatient services, whether that be diabetes or heart function clinic and cardiac rehab and all of those, they're going to start to improve our outcomes. And one thing certainly to mention, psychosocial impact. 10% of patients who go through this acute coronary syndrome will have a depression that's considered clinical level, not just down in the dumps, but true depression. So that's important, not something necessarily we get to address so much in the acute phase and before they go home, but something we can maybe be observing for in any of the follow-up outpatient clinics we've got them in, or in cardiac rehab, and certainly the family docs as well can try and get into watching for that. So these are all the kinds of things that we've gone through that we want to make sure they're on. Aspirin and plus or minus, there are other antiplatelet drugs. Some will be on prasugrel, especially if they were picked up in the field, sent right to the cath lab. Because they weren't on any antiplatelet agent beforehand, that's often where the interventionist will put them on prasugrel. Definitely statins, sometimes other therapies, and then this combination of beta blocker and ACE inhibitor and aldactone or eplerenone, if appropriate. So that, I mean, we've kind of covered it all here, I guess. These are all of the various things. Remember the spectrum of all the ACS patients, trying to make sure we identify who truly is ACS rather than, oh my gosh, the troponin is a bit above undetected, so I guess they should come in. The immediate assessment, risk stratifying, and getting their artery open as quickly as possible, whether by thrombolytic or PCI, and then deciding how aggressively we treat the unstable angina and STEMI group. And that's it. We wanted to keep at least 10 minutes for Q&A if there was any, but hopefully that was useful. It's been a while since I put together an ACS talk, so I had to try and bring everything up to date. And it's changing a lot, although most of the changes are kind of subtle things as opposed to broad sweeping changes. And so that's why I talked more in broad terms. The subtle things might be how much Plavix and which low molecular weight heparin and which antiplatelet therapy besides aspirin. And so that's going to be reflected more in our order sets, and that's why it's less important to have that committed to memory. It'll just be on the checklists. And we'll even have guidelines as to why would you pick ticagrelor over clopidogrel, for example, or why wouldn't you pick. And so we'll have that all in the order sets because that's the best way to make sure that everything's done right. But any questions?
A very quick question. I hope you didn't cover it in some calls, but we discussed coronary CT. For that in terms of ACS screening versus because there's a lot of data in the US. They seem to love it, but it seems like you're picking up a lot of people who.
Yeah, I think the problem with coronary CT is, so for those of you who may not know, there's different types of CT scanning for coronary artery disease. There's looking for calcium, and that's just kind of helping to know if atherosclerosis is there or not. And then there's looking for the actual coronary CT where they don't just look at calcium, but they actually look at, it's kind of like the poor man's angiogram, trying to see if there are lesions and how tight they are. And the thing about coronary CT is it requires a nice regular rhythm that's a slow rate, and it's, in my experience, it's fairly wishy-washy with how bad the lesion is. So if you get one that says it's like 50 to 70% stenotic, it doesn't really necessarily answer your question. Is that an old stable stenosis, or is it not? And I think the one time that I think it's useful, I tend to think of it in sort of younger patients where I think it's really unlikely to be coronary, but I would rather not send them home without that diagnosis. And so I think if it's available in that group, I think that's usually kind of an ER decision rather than once they're an admitted decision. I think if we're concerned enough to admit them, I think probably the right answer is get the proper angiogram later. Or at least the stress test. You know, it's like, I think this is pretty low risk. Funny story, but let's just put you on the treadmill and see if anything shows, because if that's negative, that's pretty reassuring. So it's very rare for me to think about it, but that's because I think maybe sometimes the ER docs do it.
We don't do it here. We're doing them in London over the
Yeah.
We're training. You have to give them a Betablocker and they have to go.
Yeah, it's a bit of a pain, but
Study at time, so I'm not sure how much you can. I know they're using a lot in the U.S. because they're so, they don't want to miss anything.
no, exactly.
It's a little different culture. Second question, if you don't mind.
Yeah, go ahead.
The new STEMI guidelines for 2013. Now, I noticed they changed the kind of the time to thrombolize versus the time to bleed. It used to be 90 minutes. If you can get in the cath lab in 90 minutes, you probably should thrombolize them. They changed that to 120 minutes. Which
Yeah, the Europeans changed it first, and then the ACCHA have changed it since as well.
I think in 90 minutes, going to South Lake is right on the cusp. Actually, get them to the cath lab and the balloon. But 120 minutes or 2 hours seems pretty reasonable to be able to get them down there for most cases. Do you think we're going to see less? Do you think we should try to get more people that have not thrombolized them and go, or just still try to do the transfer AMI kind of protocol?
Well, yeah, it's a good question, because we've been in talks with South Lake about, as I said, revamping. Maybe you were out at that point, but I said early on we did have a primary PCI program at RVH ER as well as the field, and we weren't matching it in the ER, mostly due to transportation issues, but we maintained it in the field. But we are looking into that again. And you're right, extending the window another 30 minutes can potentially make a big difference. But I would say, as far as I'm aware, we're not in that program yet. So I think if we called them, I think they'd say if it's within the 3 hours, do the transfer AMI protocol, the drip and ship. And whether we'll change that within the next couple of years or just stick with that approach until we have our own lab, and then it will be really a non-issue, I don't know. Time will tell. Sometimes it depends on how aggressively champions pursue those things. And I've got almost so many things on my plate, I'm not sure how high I rank that one. But yep. Select, Cialis, and then the third one is, which one? Levitra, yeah. See, I don't know. I have to ask these young whippersnappers. If you've taken those drugs within 24 hours, I'd say absolutely not. But
you would not be on, as a cardiac patient, on nitro. You would not be able to take.
yeah, if you take daily nitrate therapy like a patch, that's right. I would say those drugs are absolutely contraindicated. If somebody has nitro spray and they use it like almost never or sparingly, I would say that's okay for them to use those drugs, but they have to understand if they've taken it, they have to remember for the next 24 hours, no matter what happens, including angina induced by sexual activity, you're not allowed to take your nitro. And if it doesn't settle with rest alone and you kind of invoke the emergency system, whether that be ambulance or the triage nurse, you have to let everybody know along the way. So I don't favor the long-acting Cialis because that 72-hour duration of effect means they got to really remember, did I take that Saturday night or Sunday night? So I kind of always have favored the shorter-acting ones for, because it's usually easy for them to remember if they took it the day before, but they're not allowed to take it if they, and the problem is because how those drugs work is they prevent the breakdown of nitric oxide, and that's essentially what nitro is doing, is becoming a bunch of nitric oxide. So it doesn't get metabolized, it just kind of, it's like an overdose.
You know, the other day, one of the teaching sessions was about CK and troponin. Why are we doing both?
I never use CK, so I don't know why it's done.
That was the question, was why?
We could take them off if it's for that stuff as far as I'm concerned, because we don't make any decisions based on CK or CKMB. We shouldn't. I tried to pursue that once a long time ago after we got troponins, and it was back when Mike Walsh was here, and he didn't like to make any changes, it seems. So same thing with INRs and PTs, like same thing. If we're making decisions based on INR, I don't think we should have a PT reported. But I don't know. I have a feeling if we talk to the lab, they'd say it's no cheaper to have it because it's all part of the same panel. And so it's just included. And I guess, sure, I'd rather have more information than less. Like in a CBC, I usually care about hemoglobin, white count, platelet, and MCV. They give me all these other MCRC, all this other stuff or whatever. I'd rather, I suppose, have too much information, not too little, but I would never use it to make a decision. I suppose if somebody's CK was elevated, not the MB though, again, I don't care about the MB, but if somebody's CK was elevated and the troponin was undetected, that could help tell you, well, maybe the pain they're getting is muscular because what's hurt their CK. But all right, well, I hope this was